Hi, my name is Tammy Allison, and I'm the CEO and founder of Conflu3nce. Today I wanted to tell you about the Lesion Optics SaaS tools we're developing, which are designed to build knowledge outputs by enhancing image inputs. Our goal is to foster a deep learning model for all, advancing image intelligence to maximize the value of image assets. The Lesion Optics tools I'll be describing follow a set of rules to make images more accessible and increase the meaning for both humans and AI. These include VisEase, to visually enhance images by balancing ambiguity and clarity. Scores involves a serial color reduction segmentation to characterize interior, to edge, to background features using figure and ground context. And Stitch and Peel, which is used for reducing the volume and pixel complexity of images. We can apply Lesion Optics tools to improve disease detection and diagnosis, specifically as it applies to diagnostic imaging and detecting ROIs and nuance changes. To think of it another way, we want to cooperatively improve both specificity and sensitivity to get it right all the time. When it comes to disease detection and diagnosis, we want to reduce false positives, the misdiagnoses, and false negatives, the missed diagnoses. But there are challenges. The sheer volume of diagnostic images and heterogeneity of lesions makes this challenging for both humans and AI. Not surprisingly, errors occur. Clinician fatigue impacts cognition and perception. And while AI can improve efficiency, handling volume information processing and administrative tasks and helping to reduce errors by pre-screening ROIs, outsourcing to AI can also exacerbate existing human errors, and new ones can emerge, including complacency and loss of clinical skills. So how can we improve sensitivity, the true positives, and specificity, the true negatives? In other words, how can Lesion Optics reduce false positive and false negative reporting? We can begin by asking better, different questions in order to build image intelligence and advance our detection capabilities. ROIs vary in size and complexity, and for nuanced ROIs, it can be a bit like trying to find the proverbial needle in the haystack among many different sized haystacks. We can try to make the needle bigger, or the haystack smaller, or both. Make the haystack smaller and the needle bigger, or at least more obvious, as with Lesion Optics Stitch and Peel methods. SMP can build image intelligence by reducing the complexity and volume of pixel content, making it easier to detect and visualize nuanced ROIs. SMP was originally developed using non-medical images to better understand the interactions between images and image parts in defining figure and ground dynamics. In the simplest version of SMP, an image is divided into three parts: S1, S2, and S3. S2 is masked, and S1 and S3 juxtapose. SMP relies on embedded Gestalt properties, visual cues that allow us to hopscotch across spatially separated regions, in going from S1 to S3 by assessing contiguity properties, making comparisons, identifying same and different elements between two sections, identifying asymmetries, making inferences, and filling in the missing pieces of the image's story. SMP has lots of variations and applications, both in image processing and image analysis. In medical images, we can use naturally occurring symmetries. This is a CT of a patient's brain after an ischemic stroke. We can perform a stitch to compare the left and right hemispheres, looking for nuanced saliency differences. The primary lesion can be mapped, but proximal regions of altered saliency can also be identified. These are potentially at-risk but salvageable regions to stratify penumbric regions. Shown on the right is a project we've been discussing with the folks at CERN to combine SMP with CERN's superpixel algorithm in order to add a resolving layer to early detection. Dermatology provides a powerful model for early detection, and we want early detection. With skin cancers, if caught early, stage 0 to 1 melanoma has a 95 to 99% cure rate, which drops precipitously to 22% at stage 4. There's also a 25-time difference in the cost from a few hundred or $1,000 to tens and hundreds of thousands of dollars. End-user consumers can also be engaged, effectively building knowledge across all stakeholders, a participatory opportunity that is essential to prevention and early detection. Just like the needle in the haystack conundrum, lesions of all kinds present a high degree of heterogeneity and individual variation. That applies across many types of lesions and diseases. So we can't be too ambiguous, the underfitting problem, or too clarified, the overfitting challenge, yet specific enough to also be generalizable. So then how can lesion optics help advance image intelligence? In this example, we have an image of a skin lesion. It's good enough in many ways to make a referral from a family doctor, primary care physician, or a telehealth consult to a specialist, to recommend a biopsy, and even make a preliminary diagnosis. But with 21st century capabilities, it's not good enough. We're left with a lot of unanswered questions, not the least of which, what does this lesion actually look like? So how can we build image intelligence? We can apply the lesion optics Vizi's filter to generate a paired image. The image on the left is ambiguous. The one on the right, disambiguated. We don't have to squint to see the details, but we've stayed within lesion optics image manipulation preset and manual parameters. In the process, though, we've unlocked hidden data, building out image intelligence. When these images were analyzed using a sandbox pre-trained computer vision demo model, VisionBot in this case, ambiguity and clarity are also reflected in the results. With a side-by-side comparison, we're able to discern maybe why the image on the left yields a split decision, as a spider also skin, while the image on the right gives us a clear starting point, along with more features to extract and understand, and questions to ask. Both the ambiguous and clarified images are necessary for us and for AI in trying to make the black box just a little bit grayer in understanding decisioning processes. So now what? Unfortunately, the standard skin lesion melanoma ABCDE plus EFG algorithm for characterizing lesions doesn't provide us with the language to describe the lesion's interior features. These are both qualitative and quantitative analyses that we need to do. I want to thank Ash Margoob of Memorial Sloan Kettering Cancer Center in New York, along with the American Academy of Family Physicians for the use of these images. Ash developed the TADA algorithm to specifically look at lesion interior and edge features. From a pattern standpoint, these nevi are classified as organized, so we can track for progressions and transformation from an organized state to a disorganized one. But if you remember that only 20 to 30% of melanomas arise from pre-existing nevi, then these organized nevi are already highly differentiated. So from an early detection standpoint, we need to ask, what did these look like at earlier time points? And what, if any, is the connection to de novo lesions and their transformation or progression to malignant skin cancers, both for melanoma and basal cell carcinoma? This organized to disorganized transformation or progression is seen in other types of cancerous lesions, both at the macro level and at the cellular level. Our goal is good outcomes for patients, whether it's early disease detection or getting to a correct diagnosis. Thank you, and I'm happy to answer any questions.